Welcome back to Clinical Communication. Today, I'm speaking with Michelle Lyons, who is a specialist physiotherapist and international lecturer in pelvic and women's health. And today, we're discussing how to raise the topic and have conversations about menstrual cycles and periods. If you find this useful, please do go and share it with others. Please do subscribe. You can send in questions, stories, or feedback to clinicalcommunication@outlook.com. Thank you, as always, for listening or watching, and I'll speak to you next time.
For us as clinicians asking about these questions, about these issues, and for us knowing what's normal, and then if we don't have it in our toolbox to help, knowing where to send people.
Yeah, exactly. Yeah, I go like that. Know where to send. You can't
Yeah.
you can't be everything to everyone, but you
No,
can
no.
direct. Like that. Well, first of all, Michelle, thank you for your time and talking to me about menstrual health. And also to thank our mutual friend Matt Phillips, who suggested this discussion as well.
Thank you, Matt.
You are the first on this podcast of a pelvic health specialist.
Ah,
Yeah, for now, there will be more.
okay.
And we're talking today about menstrual cycles.
Yeah.
Almost from a how to discuss it, how to bring it up, the conversations that come with it. We're not going on to, the treatments of it or all the things you can do to manage it. That's for other areas. You've got an excellent podcast. And I listened to your 3-episode special on menstrual cycles
Ah,
to prepare for this.
oh, good. I have a quiz for you then for afterwards. We'll check your menstrual literacy.
So the first thing I wanted to ask was, they've got a female in front of us.
Yeah.
We think actually from what we're hearing that it may be wise to ask about their menstrual cycle. What's the best way to raise it and bring it up
Okay, so
if they haven't?
the best way to consider if asking somebody about their menstrual cycle is, do they have a menstrual cycle? If they have a menstrual cycle, you need to be asking about it.
Mm.
So everybody who has a menstrual cycle or potentially has had one at some stage, we need to ask those questions because it has a huge impact on muscles, tendons, on mental health, on endocrine function, on all, I mean, if we're talking about like MSK sports physios, maybe, coming in to see us, we know, let's say, for example, that ACLs injuries may be up to 7 times more common in female athletes than males.
Yeah, yeah.
Still some controversy about the impact of um, hormones versus early access to neuromuscular training and facilities.
Mm.
But let's say somebody's coming to see you with back pain. And on further questioning, you find out that the back pain is cyclical. It's every 3 or 4 weeks or so.
Mm.
That should automatically start to trigger some questions about your period. So t tell me about your menstrual health. And just asking an open-ended question like that, I think just opens the door. You can gauge her level of comfort talking about it, but also her level of literacy about it because we're not taught well
Mm.
about our menstrual health, whether normal people in school, but I would say even, like, I mean, admittedly, I graduated from physio in the primordial mists of time 30 years ago, but we didn't talk about the influence of the menstrual cycle or, menopause or pelvic health at all, really, at that point. Everything, as we were talking about before we started recording, was done very much through that male gaze of ACLs, rotator cuffs, back pain. But I love to quote Dr. Nika Goldberg, who's a cardiologist in New York, and she was the person who coined the phrase "women are not small men." And estrogen has about 400 different functions in the female body,
Uh-huh. Wow.
and has a huge impact on muscles, tendons, joints, bones, obviously. So if we are working with any person who has the potential to have or have had a menstrual cycle, we need to be getting some information because 1 in 9 women will have endometriosis. Um, PCOS, again, super common as well, and that has some cardiovascular and diabetes implications. Um, if somebody has heavy menstrual bleeding, even, we know that up to 40% of girls between the ages of 12 and 20 have iron deficiency anemia. And that's just not going to manifest as tiredness. That's going to be altered mood, um, fatigue, insomnia, ironically, dry skin, but muscle and joint pain, restless leg syndrome, all of those things as well. So we need to get comfortable asking, so tell me about your period. Uh, do you have any pain? How long does it last? And to know what's normal in terms of heaviness even. So we have our radar up for things like heavy menstrual bleeding or anemia, because that can often be this subtle driver behind a lot of the issues that folks might be coming in to see us for, under the guise of back pain or knee pain
Yeah.
or rotator cuff issues.
Yeah. Do you think it should be routine?
Yes.
No, fine. I was just thinking, like, we ask all these other things about, I don't know, history of rheumatological conditions in the family
Yeah.
and weight loss and, have you had any fractures?
Yeah.
I'm going to make a guess. I don't know any stats on this, but menstrual issues probably occur more than people have had fractures.
Well,
Or,
once a month.
yeah.
You know, so if you're
Yeah.
fracturing once a month, that would be problematic. But I mean, honestly, I saw a conversation on X a couple of weeks ago, and there was a physio, and he was talking about how, he's always very, very keen to take a systems approach to assessing his patients. And he was talking about somebody with back pain. I said, "Well, did you ask her about her menstrual history?" And because he quite categorically said, "I do a complete systems approach," and he was very much looking at it from that kind of rheumatology perspective,
Mm,
um, like the Screendon Paul
yeah.
Kerwin's approach,
Yeah.
which is fantastic. But again, where is the hormonal, the female
Mm,
perspective on that? Again, that's still a very male lens. Yeah, lots of it will apply, but you're leaving out a major influence in
mm,
terms of MSK potential problem drivers if you're not asking about menstrual health. Um, it's leaving it there on the field, and you might be
mm,
the person, like especially with back pain. Let's say somebody is having cyclical back pain every 4 weeks or so,
yeah.
because endometriosis can affect the sciatic nerve. It can affect the it can really, it loves to live on those uterosacral ligaments. So that kind of
Mm,
dragging sensation on the lower back, sacroiliac dysfunction. And of course, in women particularly, we know that there's a strong link between pelvic floor dysfunction and low back pain. And, we have research going back over 10 years looking at that. Michelle Smith did some showing that for women with back pain, constipation, loss of bladder control, and breathing issues were more tied to back pain in women than obesity or level of activity. And then, if someone's got repeated exposure to pain on a monthly basis, what does that mean in terms of central sensitization and nociplastic changes? So there's lots of layers to this, but it's an easy thing to ask about if
yeah.
it's just normalized, because I remember before I started in pelvic health, we used to have the Oswestry scale, and it used to have questions about sexual health when we were screening for back pain. And the questions about sexual health were taken away because physio said they were too embarrassing to ask about.
Ah,
But even screening for cauda equina issues,
yeah.
we would say, any issues with bowel or bladder. And I was the physio with my hands over my ears going, please say no, please say no, please say no. So we never have to talk about that again.
Mm,
And we really have to normalize. We're leaving out major body systems
mm,
out of our approach. And of course, like men can have pelvic health issues as well. We're obviously not talking, we're talking tonight mostly about menstrual health, but men can have pelvic floor dysfunction too.
mm,
And, whether that's pudendal neuralgia, particularly in our cyclists, but just, those type A high stress personalities. So it's a big, important center of psychological distress as well. And if we are going to be biopsychosocial practitioners, we've
yeah.
got to factor all that into our equations as well, because it's going to make us better clinicians, better detectives to solve
So,
problems.
oh yeah, absolutely. I completely agree. How how do we normalize it then? Is it just a case of saying is menstrual health? Do we say periods?
Yeah.
Um, does it matter?
I don't think
Was
it matters really. I mean, I would obviously stay away from any of the awful euphemisms that are out there. But I would just say, so just, talk to me about your periods. When was your last menstrual period? Because anybody who goes to their GP will be used to that as a question. Because I think sometimes you can go into A&E with your broken leg tucked underneath your arm, and the first thing that they will ask the females going in there, so when was your last menstrual period? But just ask, so talk to me about your periods. How are they? And they They will hopefully, feel comfortable enough with you as a clinician to answer those questions. I think a lot of it is in us setting the tone.
Right.
If we are comfortable asking about these questions, we can kind of regulate their nervous systems a little bit. But if we're fidgety and embarrassed and, oh,
Mm,
how, and clutching our forehead, I really don't want to ask this, but I know I should. So if we're uncomfortable, they're going to be uncomfortable. So it's just about getting comfortable, knowing what the normal parameters of menstrual function are,
yeah.
being able to spot a problem. And as I said, if you don't have it in your toolbox, although I'm going to put it to you that I think a lot of MSK physios can do a lot more than they think they can,
Mhm.
and when it comes to that, um, it's just about having the conversation. And if you don't want to go down that path, having a referral network, if you've got a good pelvic physio that you can refer to, or back to their doctor with a little note saying, I think this might warrant some further investigation, because, we should all be sailing in the same direction. So it's up to us to be comfortable with it.
Yeah, I agree. I've found actually, when you go through like a routine, your past medical history,
Yeah.
when I ask about night sweats,
Hmm.
sometimes people go about sinister pathology, but actually most people, especially women who ask you to, they're thinking you're talking about menopause,
Yeah.
not cancer. So actually, I found that in the past few years, that's been a nice way in
Oh, brilliant.
to
Yeah.
raise the subject because you're not starting there. You're not like they're walking in with their back pain
Yeah.
and saying, "How was your menstrual cycle?" Because that might be a bit much. Um, but usually, if you built the rapport right and the trust, and you've
Yes.
got through all that, the usual questions,
Yeah.
by the time you get to that bit about medical history,
Yeah.
and you get to then hopefully if you built the rapport and trust, they're going to answer right, and
Exactly.
they feel comfortable to answer.
Yeah.
Um, and I found that that asking night sweats, even though we think of it for something else, they would think of
Yeah.
it for that, and that seems to be an in.
Great. I mean, like that would probably be the best place to ask about menstrual issues as well,
Yeah,
and I find sometimes just asking an open-ended question like tell me about your periods, tell me about your menstrual health,
yeah,
how it is now if you are still menstruating or how it was when you were.
yeah,
Because you don't know, somebody could have had a hysterectomy
yeah,
at any age for any
yeah,
reason, cancer or otherwise. So I think just kind of being aware of that as well, and that can be a sensitive subject. As well. But it's about our confidence as clinicians to ask these important questions. Like we wouldn't dream of leaving out any other major system in the body or
yeah,
ignoring any other red flags. So if someone's coming to you and you're asking them about their period and they say, well, gosh, they're really heavy and they're really painful. Like I have to double up on pads and tampons or I'll bleed through. I have to miss school, a couple of
yeah,
days every month, or I have to miss work. Or I'm mainlining ibuprofen, for at least 3 days every month.
mm,
Those are all red flags to me that warrant a further conversation.
yeah,
And, again, could it be endometriosis driving their back pain? Um, Endometriosis loves to travel with IBS and fibromyalgia. So if we're screening for some of those kind of
mm,
chronic overlapping pain conditions that have those nociplastic changes, we know that things like endo particularly loves to live with that crowd and run with that crowd of IBS and fibromyalgia and TMJ issues. So there's always a way to get in some questions about pelvic health that I think can be really revealing. Um, Sinead Dufour's work, her research, I think that was like 2018 or so, looking at women with back pain. About 90% of them have some sort of pelvic floor dysfunction.
mm,
Um, and almost always overactive, like an upregulated pelvic floor. So it's not just about giving somebody, Kegel type tighten, tighten, tighten pelvic floor exercise. We actually need to down train the
yeah,
pelvic floor and reestablish a little bit of coordination. But like honestly, urination and having a bowel movement, they're some of our most basic bodily functions. And if we can't do those properly, and if that's affecting our back pain, for
yeah,
example,
yeah,
you
yeah,
know, it can give you some great easy wins in MSK health,
yeah.
if you can just widen the lens a little bit.
If they say, actually, yeah, my period's really painful,
Mm.
but I don't know why.
Hmm.
Like, let's just say I've not seen anyone, I haven't raised it.
Yeah.
And let's say this is a person who is not a pelvic health expert.
Yeah.
And they say, what should we say? I know, obviously, as you said, refer on to where, but should we ask, are there other things we should ask to kind of guide this?
Yeah, I mean, you could ask a little more like, is it disrupting your life? Is
Mm.
it stopping you doing things you want to do in terms of sport or school or university or work? Um, is and to know what the criteria are for heavy menstrual bleeding, like a period that lasts longer than 7 days, that's a big red flag. But as I said, needing to double up on menstrual supplies like pads or tampons, passing clots that are bigger than let's say a pound coin, and pain. Those are kind of
Mm.
the big things. But not just pain with menstruation, but pain with bowel movements, particularly.
Mm.
That's a big red flag for endometriosis. Um, but there's a huge role for physio management of dysmenorrhea and endometriosis. And I'm going to just, slide it into the conversation here. I
Okay.
did a clinical commentary for the Journal of Pelvic Obs and Gynae Physios towards the end of last year on physio management of dysmenorrhea and endo. And I'm happy to share that with anybody who'd like a
Yeah.
look at that. But it's looking at the evidence from a physio perspective of what we can do. Because things like TENS machines, which were poo-pooed for a long time, are actually having a little bit of a resurgence
Ah.
in popularity in terms of pain management for menstrual pain, but also for things like bladder urgency frequency. We can
Yeah.
do some tibial nerve stimulation, so the electrodes go on the inner aspect of the lower leg,
Yes, I'm
and we
with
can
you.
do some neuromodulation of the sacral nerves via that tibial branch.
Yeah.
Um, but advice about exercise, advice about sleep hygiene, good bowel health, and then any pelvic floor muscle retraining that needs to be done as well. Like that's obviously a little bit more specialist
Yeah.
pelvic physio, but there's a lot that we can do to lower the load. And I think sometimes even just explaining that to people and saying, you're not the only one, because they
Mm.
may have been gaslit, honestly,
Yeah.
in the past, because I would say particular for issues like endometriosis, they tend to run in families. So menstrual pain almost becomes normalized.
Ah.
Well, my periods are really painful, but I said it to my mother and she said her periods are really normal. They might get better after you have a baby, or you might have to wait until menopause. And my auntie and my granny were the same, so surely this is normal. And this is when you have to say, actually, no, you don't have to
Mm.
to deal with this. Um, so education is a big part of what we do.
Yeah.
Um, as I said, like knowing what's normal, knowing what's dysfunctional, and then signposting people to solutions.
Yeah. What if they don't know? I'm thinking people on contraception. You
Yeah,
re-ask the question, how is menstrual health?
yeah,
How are your periods? And they don't know.
yeah. That's fine.
We can't
Like
do
if
anything.
they're
Can we do anything with that?
you really can't. I mean, for I would say probably for about 80% of people using oral contraceptives,
Mm.
they work beautifully. And in
Mm.
fact, they can be a really useful treatment strategy for period pain and for endometriosis.
Yeah.
Um, like the gold standard for endo for a long time was surgical excision, with kind of, prehab and then pelvic rehab afterwards.
Mm.
But now what we're looking at doing is using a combination of medical approaches, so
Mm.
using something like the pill, um, one surgery, and then kind of, pelvic physio afterwards, to kind of again lower that inflammatory load and reestablish a good quality of life. So the pill can be fantastic, obviously for its designed purpose as well, can be a great source of contraception, can really help regulate the regularity of the cycle as well. So again, for an athlete who may not want to have her period, particularly if she's, competing at Wimbledon, let's say, and she has to be in all whites, it gives female athletes a certain level of control.
Mm.
Um, can lighten the menstrual flow, so she's at less risk of developing iron deficiency or anemia. For about 20% of people, they don't do well on the pill. And
Okay.
they can actually have like a genetic sensitivity. The androgen receptors in around the vulva can become very unhappy because it will lower the testosterone without getting too technical, and they can end up with some pelvic pain issues. But there are lots of different types of oral contraceptive pills. There's been a bit of a trend on social media with a lot of wellness influencers
Right.
to knock the pill,
Ah.
and that women shouldn't be on it. It will give you PCOS and it can cause all these different problems. It will really damage your fertility. But if you actually look at the evidence and the science, that is not borne out.
Mm.
So be careful where you get your where not only where we get, but where our patients are getting their information from as well.
Yeah.
And again, this means that we have to be really kind of solid in our footing in understanding the issues. If we're going to have these conversations, we need to be sure we know what we're talking about.
Yeah. And
Um, but IUDs are another great option as well. So it's
mm,
just there's a bit of nuance to it. But if someone's on the pill, they're not going to have a menstrual cycle. So you just ask them how they're doing.
yeah.
Generally, bowel health would be my second favorite thing to track after menstrual
Ah,
cycle tracking,
okay.
because that's again, particularly for your female patients, that link between constipation and back pain and the gut-brain axis and mental health. That can give you some really good information as well. And, having conversations about constipation is not something I thought I'd be doing when I was a baby physio working in sports medicine, but it is literally one of my favorite things to talk about now because it's hugely important.
And we're talking about on that subject then,
Mm.
is that if you're raising that, say they don't know, you raise up about the bowel health.
Mhm.
Are we talking frequency? Are we talking
Yeah.
pain, or just
Yep.
how is it in general?
Open-ended questions, how is it in general? I'm always quite interested in knowing like how often you're having a bowel movement. Um, I am very prone to whipping out my Bristol stool chart so we can talk about size and shape. I have a coffee mug with the Bristol stool chart printed on it, so it's a great conversation starter
Yeah.
because it's a great way to again start tuning into your own body and becoming an expert on yourself. So in the same way that, certainly for our athletes, we're talking about tracking sleep and tracking food in and food out, bowel movements can give you a really good indication of what's going on because
Mm.
it's a really good stress barometer for most of us. Like most of us know that when we're stressed, we have a bowel reaction. We either trend towards constipation or looser stools, maybe towards the diarrhea end of the spectrum.
Yeah.
So I think that can give us a good indication. But normal, is anywhere from 3 times a day to 3 times a week. Those are your parameters of normal. But what I'm interested in is has there been any change of late in
Mm.
conjunction with why you're coming to see me today?
Okay.
Because that, if if the constipation and the back pain are kind of evolving together,
Yeah.
that's going to start me thinking, well, could it be your pelvic floor muscles that are a little bit overactive and unhappy with you?
Yeah.
Because that would be that kind of common link between the two.
Yeah. And we were asking about cauda and bowels come up in that, so it's not. I know it's not that big of a jump to be
Shouldn't
asked.
be.
Shouldn't be,
Shouldn't be. We should all have a little Bristol stool chart in our office, that we can ask about this. But just even asking, any pain, any blood in the stool, obviously would be a big red flag for things
Yeah.
like colorectal cancer or
Yeah.
hemorrhoids or fissures. But again, it's about our level of comfort in asking these questions and
Mm.
not leaving out these really important sources of information about a person's overall health.
Yeah. One of the big things I took away from the stuff I listened that you did was about tracking periods.
Yes,
Yes.
obsessed.
Um, and I'll be honest, my wife was, especially when having children, tracking her periods. How can we encourage women to track their periods? What have you found helps encourage that and get buy-in for that in a way?
Yeah, it's never been easier to be honest because there's so many apps that you can get now for your phone. And most of us, and again, I'll put my hand up here, my phone it feels like sometimes it's surgically attached.
Yeah.
But there's some great apps out there for free. And it's just, pen and paper works just as well, or a diary or a calendar. And just to track, day one is when you start bleeding, and then you kind of track it on from there. And I think it can be quite useful to have a couple of different metrics to track. So maybe when you get into bed at the end of the day, and you're filling in, let's say you're on day 14 of your cycle. Okay, so you're in and around ovulation, let's say. So you're very fertile. So if you're trying not to get pregnant,
Mm.
this would be a time to take some extra precautions. But you should be feeling, kind of hormones. Your estrogen levels are going to be high. You're not going to have any progesterone issues. So that's normally when, a lot of women are feeling good, high energy.
Yeah.
As you move, let's say, more into the luteal phase, you've got a bit more progesterone. That's when sometimes women can be a bit more prone to things like constipation. Okay, so if you know you're a bit more prone to constipation, what can you do in terms of anti-constipation measures? Well, we know that abdominal massage, prunes, prune juice, fruit and veg in general, well hydrated, some gentle yoga, 20-minute walk, all of those have been shown to be really effective for managing constipation. As you move through that luteal phase closer to your period, A lot of women the day before the first day of their period, they tend to get trend a little bit more towards diarrhea, period poos, as they're colloquially called.
Ah,
So that might be a time to avoid alcohol, spicy food, a lot of coffee, because that can all like stimulate bowel motility. Um, and so you can get really tuned in to, I sleep really well in my luteal phase, but I know I can run a little bit hot as well because progesterone can raise your core temperature a little bit. So just to make sure that I'm remembering to leave the window open. I know, let's say that when I get my period, that's a time of low energy for me. And this is like just sweeping generalization. Everybody can be a little bit different. So that might be a time instead of going and pounding it out in the treadmill or lifting super heavy weights or trying to do some high neuromuscular coordination exercise, that might be a time for
mm,
more restorative yoga, a little bit of stretch work. And then as you move through and beyond, like after the period and into that follicular phase when estrogen is rising again, for some women that's a time when you will want to do a little bit more speed work, a little bit more running,
mm.
but N equals one. And it's
Yeah.
about when you're really familiar with, well, I know generally this is how I feel at this point in my cycle, you can really start to get quite accurate in your daily programming. And not just from, I mean, this all started, of course, with work with high level athletes, but every woman has this inbuilt, tracking data available to them, if we're telling them about it. And it's literally a simple, some of the apps you're just like, checking off a box.
Yeah.
Um, you can be as detailed as you want if you're doing pen and paper, but you get to plan, kind of what's going to suit you best throughout your cycle, and to know what you need in order to live well at each distinct phase. Because men have a 24-hour hormonal cycle,
Mm.
which is why the traditional workday is the way it is. Because for men, cortisol and testosterone peak in the morning, and by
Ah.
about 5 or 6 in the evening, they're fading away a little
Yeah.
bit. So that's why we have the traditional workday the way we have.
Ah.
But for
Ah.
women, it is that 28 to 35 day cycle, and things should have a fairly reliable pattern throughout those 4 weeks or so. And so you can just really get tuned in. But, my period was a few days late. Oh yeah, well that's because I had that really stressful thing at work.
Mm.
Because stress can throw off any aspect of it. Of course, as you said, that this becomes even more important if you're trying to get pregnant or equally trying not to
Not
get
to get
pregnant.
pregnant. Yeah. Yeah. Yeah.
Um, you can really bring that level of detail to your own life. Um, you know, within the rules of the society that we live in, and having to go out and make a crust as well. But just kind of being kind to yourself starts with knowing yourself and just giving women that information about this fifth vital sign that they have.
Yeah. Absolutely. And the app, you said apps, pen and paper.
Yeah.
My wife's involved in taking a temperature every morning for some, but I presume that's more
Hmm.
for ovulation. But it doesn't have
Yep.
to be as detailed as that. It can just literally be
It
looking
can
up.
be. I mean, you can look at, the day that you're on, like again, starting from day one, your basal body temperature every morning. Because just before you ovulate, that temperature is going to drop and then it's going to rise again. So you can track your fertility that way. You
Yeah.
can track your cervical mucus. You can track your mood.
Mm.
There's lots of different insights in, but ideally, if you're not on hormonal contraception, whether that's the IUD or the pill, um, you've got that kind of, as I said, monthly event,
Mm.
um, menstruation, but also ovulation. Ovulation is probably the most important part of the menstrual cycle, um, because menstruation is the one that gets all the glory, but it's actually ovulation when we get that progesterone hit, and that's what really balances out our hormones as much as that's possible, because estrogen left to its own devices can get up to a lot of mischief.
Mm.
So we need to make sure that we're ovulating as well, because ovulation is how we produce progesterone, and estrogen is kind of like the fertilizer that you put in your lawn to make the grass grow, and
Okay.
progesterone is like the lawnmower to keep things in check. So you need a little bit of both and a little bit of testosterone thrown into the mix as well for muscle building and mood and libido and all that good stuff. And they all should hopefully swim in harmony with each other and the rest of the endocrine system.
And I'm thinking a certain, because we were talking about earlier about taboo, all right? And
Yeah.
people talk about it more. One thing I would ask was about there'll be certain groups, ethnic groups, something like that, where it's
Yeah.
still not talked about that much. And especially with those groups of women,
Hmm.
especially with a male clinician in front of them,
Yeah.
it could be particularly touchy.
Yeah.
How does one manage that?
Well, you can introduce the topic and you can ask them if they'd be interested in learning more about it. And if it is kind of a cultural male female issue, this is where having posters and having brochures or even just, links to websites that you can send them to where they can get more information about it. It's meeting people where they're at in
Yeah.
terms of their comfort level. Um, I mean, it's giving them the option and letting them choose for
Mm.
themselves what they want to do.
Yes, so ultimately it's down to them, isn't it? They don't have
Yeah,
to talk about it.
no,
Um, it has to be the right time, I guess, doesn't it?
yeah, absolutely. They have to feel safe in having those conversations, or it just defeats the whole purpose.
Mm. And any way that, apart from, as you say, raising it, giving them space, especially
Hmm.
for men asking these questions, any other, sometimes it maybe feel more natural because it's coming from another woman, but if it's a man
Yeah.
raising it, anything else we should consider?
Yeah, I'll tell you, here's my top tip.
Go on.
The Endometriosis Association of Australia
Hmm.
have produced these great posters about endo, particularly, and endo for female athletes. And I have found that if you put them on the back of the bathroom door,
Right.
because for women especially, we go into the cubicle, we close the door, and we're sitting down, and you've kind of captive audience there for that information
Yeah.
dissemination. So that is my top tip. And then if you have any questions, ask your physio. You can just kind of
Ah.
tag that on at the bottom, and it opens the door for them to have the conversation. They know that you know about it,
Mm.
and they know that you're willing and able to have a conversation about it. And if we've done our part in creating that, that mythical therapeutic alliance that we're all supposed to be striving for,
Yeah.
then that might be the gateway towards them feeling safe enough to have the conversation with you.
Uh, Aside from what we've said, is there other things about discussing menstrual health and the comms around it that you wanted to raise that we've missed?
I suppose just an awareness of the ubiquity of iron deficiency,
Mm.
particularly in young women, but that also can be a big problem at perimenopause as well, because periods can go absolutely crazy at perimenopause. They can become really heavy, really crampy, and even for people with endometriosis, where it was well controlled during the reproductive years, things can go a little bit haywire at perimenopause, precisely because you can still be having periods, you're menstruating, but you might not be ovulating. So you don't have that calming progesterone to control things.
Mm.
But also, I feel that a lot of the issues around perimenopause that we blame on hormones, quote unquote, could actually be due to iron deficiency anemia as well. Fatigue, joint pain, mood changes, loss of focus, the brain fog, even hair loss, things like that. So it's really important if we're seeing women at midlife for,
Mm.
again, those MSK issues and we're asking them not only about their menstrual health at that point, but we're also if they're over 35, really we need to be considering perimenopause because it is that 15 years or so up until that last menstrual period, about 51 or 52. Um, are they having any vasomotor symptoms in particular? Those hot flushes, you're already talking about the night sweats.
Mm.
So it might be a good no harm to, instead of just having night sweats slash hot flushes. And that way you're covering the red flags for anything more sinister, but you're also introducing the concept of normalizing vasomotor symptoms as part of your screening. Because that might elucidate why they've developed this gluteal tendinopathy or this
Mm.
posterior tibial tendon issue that, often misdiagnosed as plantar fasciitis. And then you can go a little bit further into that menopausal health and you can ask them about their periods and have they had any blood work done?
Mm.
Not necessarily from a hormonal level perspective, but just to rule out things like iron deficiency or thyroid dysfunction, which I think can be really tricky masqueraders for MSK health
Yeah.
at that particular life phase, especially.
Yeah. Yeah. Yeah, thyroid. Yeah. There's something we just don't think about. It's not even in the barely
Yeah.
in the list, is it? No.
Yeah, and
No.
again, thyroid and estrogen, they love to travel together. If one of them is up to a bit of trickery, then the other one will tend to join in as well. And these really diffuse symptoms as well, they can be quite nebulous, can't they?
Yeah,
So it's all about, again, circling back to their menstrual health, and any symptoms that are associated with that.
absolutely. Michelle, I ask everyone this, and I knew this question was coming, and I don't mind if it's pelvic health related or anything related.
Okay.
What's been your hardest clinical conversation?
Um, One of the patients that I saw in my early career in pelvic health, and I was seeing her for endometriosis and a lot of abdominal pelvic pain, a lot of central changes and catastrophizing and MSK issues and a lot of kinesiophobia there. And we were starting to make progress,
Hmm.
lifestyle changes, a little bit of sub-threat manual therapy, exercise prescription, sleep hygiene, all those things, TENS for pain management. And then she went to see a gynae
Hmm.
who did some laparoscopic investigations, who told her that when he looked inside, it was as if somebody had poured cement into the center of her body.
Oh,
Yeah, exactly. I mean,
mm,
that was such a strong image for her. It set her back so much
yeah,
because what's the point? What's the point of even trying if this is what it's like on the inside? And it was about kind of being able to refer back to the progress that we'd been making and that we would continue to make, and just really trying to steer away from that damaging language and nociceptive input, frankly,
yeah,
that he was towards her, and to try and turn her around. And it took a long time, and I'm not sure that she ever really entirely was able to shake that off. I mean, I'm still talking about it 20 years later. It's stuck with me, so I can only imagine that it's
yeah,
it's definitely stuck with her. But I thought we have to be so careful with our language.
yeah,
And I don't know if he was trying to be dramatic or humorous, or just to really set a low bar for her expectations. Um, but it was one of the most damaging conversations that I ever had reported back to me from a medical colleague. And it
yeah.
really it opened my eyes to the power of
Mm.
a casual throwaway comment.
Yes, because you can't unhear it.
No, no,
Like, even if, I mean, there's various stuff about it. This isn't just for healthcare, but if something gets out there,
yeah,
even if it is later disproven, because it's been heard first, it's more likely
yes.
to stick.
But we see that, don't we, with all of the worry about hormone therapy and menopause from that
Mm,
WHI study that came out in 2002, that hormone therapy is going to give you breast cancer, it's going to give you a stroke, and millions of women overnight came off it.
mm,
And even now, still,
yeah,
I'm still trying to have the conversations about the safety of local vaginal estrogen for pelvic health issues, even of systemic. And I'm not a prescriber, and I'm not cosplaying being a gynae or a doctor, but I have the luxury of time to talk to people and to be able to show them the research and say, well, the type of hormone therapy that we're using now is very, very safe,
mm,
and works really well in conjunction with all the lifestyle stuff that we're going to be talking about. But I don't want to get breast cancer. I'm
yeah,
still hearing that 25 years later.
mm,
So again, just those memes that can go out, and they capture the public imagination so quickly, and they're so hard to shake off even after they've been disproven years later.
we found a way around that to kind of, apart from giving, you say, like telling evidence and up to date stuff, but anything else you found
It's
a way
it's
around it?
literally it's being able to sit down with people and say, and show them actually that the same people who did that research later recanted, and
Mm,
to show them like up to date research. And again, like over the past 2 or 3 years, we're lucky we've had an avalanche of research in this field.
mm,
Um, just to show, look, here's the latest safety data, particularly for topical estrogen, which can be such a game changer for the pelvic health issues that can arise at menopause, in conjunction with pelvic rehab and lifestyle. It's never just one and done with
yeah,
these things, but it's to show women the safety profile and just to explain it to them, as rational adults, and not to patronize them, or talk down to them, but being able to say, you meet people where they're at. But
yeah,
for most people, when I'm able to pull up all these studies and explain things to them, that's the older research on older types of hormone therapy, this is where we are now in 2025.
Yeah.
And let's, a 3-month trial once everybody's on board. But we do still have a couple of docs who are still working off older information as
Mm.
well, and that kind of makes it a bit more challenging. I mean, you've probably seen that paper, that it takes about 17 years for
Yes.
research to trickle
Yeah.
down into practice. Yeah, we do love that paper. But that's doubly so for hormone therapy because that fear of what if I give my patient cancer is still
Mm.
quite strong.
Yeah.
It's changing and it's evolving, particularly with the new generation of gynecologists and particularly urologists who are dealing with this, but change is slow sometimes.
Of course. Of course. I was going to ask you last, is awareness of menstrual health issues on the rise? But I think we've answered that already with clearly with a yes. Um, are there any areas of it that aren't as awareness isn't as raised about, or you think hasn't been talked about as much yet?
I think the impact of lifestyle factors has not been talked about. I mean, when people think menstrual pain, the first thing they probably think of is either your hot water bottle and your ibuprofen or going to the doctor and being put on the pill.
Mm.
But there's an awful lot that we can do from a lifestyle perspective, from nutrition. We know that like this primarily plant-based, healthy, whole food, Mediterranean style diet, very little red meat, maybe minimal dairy as well. Going for your omega-3 dominant kind of food groups. Exercise, because exercise is how we eliminate excess estrogen through the digestive system, a little bit through the bladder as well. We know that mindfulness can be really helpful, but pelvic floor rehab can
Mm.
really be an absolute game changer for this as well because our brains and our pelvic floor muscles they're in constant conversation with each other. It's a really psychologically sensitive part of our body.
Yeah.
And when our bodies experience one painful aspect, the nervous system starts to anticipate pain with another similar episode. So the pelvic floor muscles are already up like this. They're very overactive and they're trying to protect you.
Yeah.
And so calming the pelvic floor muscles down, restoring good hip mobility, good lumbopelvic mobility. I mean, things like yoga, acupressure, walking, all of those things, even moderate to vigorous physical activity, all really, really beneficial for menstrual pain management.
Mm.
And I think that aspect of our role particularly is a little bit underplayed, and we need to shout about it a little bit more. So it's not just about medicating the problem away, it's actually just about lowering that inflammatory load and giving women the tools to self-manage if that's enough. And then if they need more, there's more out there.
Of course, absolutely. Yes, changing the order of what you access, sort of
Yeah,
what you go for first, rather than just yeah, absolutely. And
education.
and on that subject, as is in the background behind you, and as I was alluding to earlier, so you have the Celebrate, and I'll get this right, Muliebrity
Oh, well
podcast.
done.
Thank
Well
you. You
done.
did correct me earlier. Uh,
But it's
uh,
stuck, so that's good.
it's a stick, which I listened to. I will admit, in the hour and a half of listening to those episodes about periods, I learnt more than I'd learnt in the 30 odd years before.
Oh, thank you.
And you also have a website with courses. Are the
Yeah.
courses for clinicians and patients?
No, they're just for clinicians.
Just for clinicians. Okay.
Yeah, for fellow nerds about women's health. So listen, there's everything there from hormonal health, menstrual, maternal, menopause to pelvic pain diagnoses like endometriosis or vulvodynia or interstitial cystitis to bowel health, because of course, women's bowel health is different, and women in back pain, and then breast and gynae oncology rehab as well. So I'm multi-passionate about women's health and about reading research and just translating it into clinically applicable, hopefully useful information.
Yeah, yeah, yeah. And you're on Instagram
Yes,
and LinkedIn and a
yes,
bit of X/Twitter, but
a little
mostly the other
bit,
two, a little bit.
mostly
Uh,
Instagram.
Anywhere, and that's under the Celebrate Muliebrity. Is that
So
right?
on Instagram, it's Michelle Lyons underscore Muliarity.
Okay, okay. Anywhere else people can find you?
Those are probably the main places. I'll be popping up at different conferences. I'll be in Ayuga in Barcelona next month, and I'll be at Pelvicon in September, And then, of course, the POGP conference in Edinburgh in October. So if you're at any of those, come and say hello. And I'll be at the Sports Therapy Association.
Oh yeah.
Yes, in
Ooh.
Exmouth. So that is coming up in the autumn as well. So
Ooh.
yeah, I'd love to see any of the listeners there come up and say hello and nerd out with me about hormonal health.
Can you say what you're talking about at the sports therapy one?
I'm actually going to be talking about menstrual health.
Oh, there we go. I've
So
set you up
this
here.
is a you have perfectly set me up. Thank you, Ben. It's almost as if we practiced.
Matt's really gonna like
Uh,
this.
well, it's about the link between menstrual health and musculoskeletal health,
Okay.
and about screening. So a lot of, things about the things that we've talked about, but then also a bit of REDS and PCOS and just optimizing menstrual health and tracking and all that good stuff.
Grand. Anything else you want to say or cover before we go?
No, I really appreciate the conversation. Just to spread the word about, I think for us as clinicians, getting comfortable with this as a subject, it's it's really great to see it kind of coming out of the shadows because for a long time, I think women's health physio and now pelvic health physio, because of course everybody's got a pelvic floor, um, we were the people who went off to the scary rooms and we had the scary cupboards with all the scary things in
Mm,
physio clinics and hospital
yeah.
departments. And it's to normalize pelvic health and to make sure that even if you're not treating pelvic health, that you're still screening for any pelvic health issues, whether that's menstrual, bladder, bowel, sexual, any of the pelvic pain diagnoses that affect, as I said, endo affecting 1 in 9 women worldwide. So it's to have awareness about that and comfort in talking about this. And yeah, there's pelvic health is really just a subdivision of MSK.
Mm.
We're it's one of my colleagues in the States talks about it being like orthopedics in a cave. So don't be afraid of pelvic health or particularly menstrual health. And yeah, reach out and if you want to have a conversation about it, I'm always happy to chat.
Grand, grand. Thank you, Michelle. It's been grand.
My pleasure, Ben. Thanks for having me.